Hi, I'm Dr. Jack West, medical oncologist in Seattle, Washington, coming today from Madrid, where I'm here for the ESMO 2017 meeting, which has been very exciting, especially in the field of lung cancer, which was the focus of the entire first presidential session here. And I wanted to cover one of the most important presentations, which was done by my friend and colleague, Dr. Suresh Ramalingam. This was on the FLAURA trial. Now, FLAURA is a randomized phase 3 trial in the first-line setting for EGFR mutation-positive patients, looking at the question of whether the third-generation EGFR TKI osimertinib is significantly superior to standard of care treatment with one of the first-generation EGFR TKIs, either gefitinib or erlotinib. In this study, patients who hadn't received prior systemic therapy and have an activating EGFR mutation were randomized 1-to-1 to either gefitinib or erlotinib. Actually, 2/3 received gefitinib in the standard of care arm, or osimertinib. A total of 556 patients were enrolled on the study, and it was about 2/3 Asian patients, about 1/3 Western population, about 2/3 never smokers, and about 20% of patients in the two arms had brain metastases at the time of enrollment. The primary endpoint of the study was progression-free survival, and we knew from a press release that the study was positive, at least for a statistically significant benefit in progression-free survival. But whether this was really a practice-changing presentation would really be an issue of whether the absolute difference in progression-free survival was enough to justify losing osimertinib as a second-line treatment, because it is currently FDA approved as a second-line therapy for patients who have demonstrated prior progression on another EGFR TKI and have the acquired resistance mutation T790M seen in about 50 to 60% of patients at the time of acquired resistance. So is the progression-free survival benefit enough in the absolute terms to justify giving up a second line of therapy? The study, I would say, was enough to change our practice. It was really impressive to see the progression-free survival curve by investigator assessment that I'm showing here. The hazard ratio is 0.46, highly significant, major separation of the curves that starts early and is sustained and over a very long time, over a couple of years. The median progression-free survival is about 19 months with osimertinib and 10.2 months with standard of care, gefitinib or erlotinib. And that's really exactly what we would expect to see with the standard of care treatment. So that arm is not underperforming. Now, importantly, when we look at the different subgroups of patients, the progression-free survival is the same magnitude, and osimertinib outperforms standard of care treatment across all different clinical parameters, whether you're looking at sex or age or race of the patient, smoking history, importantly, looking at both exon 19 mutations and the L858R substitutions on exon 21, the two major EGFR mutations, same superiority of osimertinib in all of these groups. And Dr. Ramalingam also showed that in patients with or without brain metastases at the time of initial diagnosis, osimertinib had a very comparable, very superior progression-free survival, really essentially identical in those two groups of patients. Now, when we turn to response rate, there's not a big difference. There's really a ceiling here where you get about a 75% to 80% response rate with any of these commonly used EGFR TKIs. Osimertinib was 80%, so really quite good, compared to 76% with standard of care. But the duration of response is far greater in the recipients of osimertinib, with a median of 17.2 months, twice that of standard of care, where it was 8.5 months. So let's turn also to overall survival, which has been essentially a holy grail to find a difference in a population like driver mutation patients, EGFR mutation patients, typically living 2-3 years or more, which is great, but it makes it difficult to detect any differences in overall survival when you're looking at a randomization of a first-line therapy, and patients are then likely to get subsequent several lines of therapy over the next couple of years. Nevertheless, the overall survival differences are apparent here with a separation of the curves I'm showing and a hazard ratio of 0.63. Now, Dr. Ramalingam and colleagues made a point that the p-value of 0.0068, as impressive as that is not actually what we can consider statistically significant, because we need to have a higher threshold because of this early look by the O'Brien-Fleming rule. I should also mention that the overall survival results are really still quite immature. This is only 25% maturity, but it's extremely encouraging when you see this overall survival combined with the profound difference in progression-free survival that was reported. Of course, efficacy isn't the only aspect to think about, and toxicity is quite critical, especially when we're talking about a treatment that we hope our patients are going to be receiving for 1 or more years. In fact, what we saw was a well-tolerated therapy in both arms, but less toxicity, less grade 3 and 4 toxicity, and specifically less rash and dermatitis, and lower rates of LFT elevations in the patients who were randomized to osimertinib compared to those who were randomized to standard of care. And so when we put this all together, this major difference in efficacy and a modest improvement even in terms of tolerability, osimertinib is clearly an impressive option, and one that Dr. Ramalingam said in his concluding statement on the final slide of results should be considered a standard of care. I would go further, and I think that we really need to consider whether osimertinib should be considered the standard of care, the clear best choice. In my mind, this is what I am going to be inclined to pursue for my patients as soon as I can get it for them, if they are newly diagnosed, and even if they're already on erlotinib in my practice, or occasionally another EGFR TKI, I'm going to be inclined to switch them to osimertinib, because I would say that the efficacy differences are really striking, and it's impressive to see this hazard ratio of 0.63 for overall survival. Whether you consider it technically, statistically significant or not, it's quite an achievement, combined with the progression-free survival and the greater tolerability. And in fact, even though Dr. Ramalingam and the study really didn't focus on intracranial activity, we also know that osimertinib has far greater intracranial activity to treat or prevent brain metastases than other EGFR TKIs. So I would say that it is very compelling to favor osimertinib at this point. The leading concern is really, I would say, just the cost, which is greater than other options, especially as generics come into the market as an option for the future. Nevertheless, the choice that I would be inclined to make right now is osimertinib, and I think it can and should change practice as soon as patients can get it, as soon as the FDA approves it, which I hope will be quite soon. Anyway, I will have other summaries of additional presentations in the coming days, but I hope this is helpful. I welcome your comments.